And so Duane is the medical director for behavioral health, California Medicaid Division, again, Anthem Blue Cross. He completed his undergraduate degree at Princeton University, went to medical school at the University of Southern California, and he now called the Keck School of Medicine, and a psychiatry residency at Harbor General UCLA Med Center. He opened his psychiatric private practice in West Los Angeles, and he also served as medical director at D.D. Hirsch. You know, all these places. Taught at the Department of Biobehavioral Services at UCLA Med School and served in California's statewide council on mentally ill offenders. He's been developing an interest in severely mentally ill, stigma reduction, and the intersection between mental health and criminal justice systems. And he spent 4 years in New Zealand and Samoa, returned to California providing psychiatric care, inpatient and assertive outpatient psychiatric services in settings before he went to Anthem Blue Cross, and now as the medical director for behavioral health. So why don't we actually hear from you first, Duane, and then I'll go ahead and introduce you, Joe, right after.
Oh, okay. Well, thanks everyone for coming this afternoon. Joe and I had envisioned that this would be a much more interactive rather than didactic presentation, so I was actually surprised when I walked in and saw the lectern here, but we'll do what we can. What we thought we'd do is mention a couple of the challenges, which I now know are fairly universal based on the discussions that we've had yesterday afternoon and this morning. So we'll mention those, and then what I thought we'd do is maybe talk about a couple of actual cases, your actual cases, and I will change the names and ages and all of that stuff to make them less identifiable. But just to illustrate some of the challenges that we've had and perhaps a success and a maybe success. And maybe this will generate some discussion among us about some of these challenges and how we are facing them. So with that, let me just get a sense. So would that be okay with people, that kind of, or are you expecting an hour lecture and 57 slides? I mean, because 127 slides? Okay. All right, so then that's what we'll do. I think now, Joe, you had a list of the challenges that you wanted to make sure that we hit. Let me just excuse me. Let me just mention one, which is a big challenge, especially in our northern counties. As was said, my responsibility is statewide, as is Joe's. There are, and you know, in California we're peculiar because we're California. California doesn't have one way of delivering behavioral health care. California has 58 ways of delivering behavioral health care. And that is something that Anthem, which is part of WellPoint, which is a national, nearly international enterprise, that is something that they came to understand slowly, but fortunately for me, they came to understand it in time for me to get the job, because what they needed was someone who understood that California has these various ways of delivering health care because the counties are the seat of delivery of health care, and especially behavioral health care. So Anthem, which is in how many counties, Joe?
29.
So Anthem's Medicaid or Medi-Cal functions are in 29 of those counties. So we have 29 different ways of helping to deliver this new behavioral health benefit that has come to Anthem and to the counties. So one of the struggles, which I think is universal, and it was mentioned in several of the discussions, is this business of mild to moderate versus moderate to severe health care, and what happens. We're not talking about a population that is static by any means. It's not that you can get an evaluation and you're determined to be mild to moderate and that's where you stay, right? We have people who appear to be mild to moderate and then they become severe, and then people who appear to be severe and then become mild to moderate. So one of the challenges that we have in all of our counties is negotiating that boundary. Figuring out, first of all, who gets to decide, in most counties, it is the county mental health folks who get to decide, and that makes sense. Who communicates that? How is that communicated? How often is it assessed and reassessed? And when it changes, how is that communicated? And then how are those funding streams negotiated? So I see lots of nodding heads and mm-hms as I say that. So I'm guessing that that's something that we all are struggle with. Well, some of us are probably struggling with it. Some of us are probably just trying to figure it out and negotiating it. And I don't know, is there a county that has, other than San Diego, which clearly is the gold standard? I mean, those people are sitting around every month talking amongst themselves, and they don't care who pays for care. Oh, that patient went there, fine. Well, I want that when I grow up. I've told them I'm going down to say, I'm going to come to some of those meetings because I want to see this kumbaya thing you've got going. And I don't doubt it, I just need to see it. Was it Reagan who said trust but verify? So I want to see that. But aside from San Diego, does anyone else have a situation like that where really it just doesn't matter who goes to what provider, that you just get it done? No one? Okay, all right. So I think we all need to go down to San Diego and drink some of what they're drinking. So that's one of the challenges that it turns out seems to be universal. Another challenge that we have is providers, specifically psychiatric providers. And pointed out really well with the last panel is ethnically or culturally appropriate providers. Dr. De La Cruz and I had a discussion a week or two ago about finding psychiatrists who are willing to see our folks in the community, and what a challenge that is. And it's a challenge not only for us as a mental health plan, it's a challenge for you all as providers, as people who run mental health agencies, trying to find folks who will come and work with you and see those folks. It's my experience from my years at D.D. Hirsch that once you find them, there's a big chunk of them, if you find them and you treat them well, they're going to stay. But there is still a certain amount of churn, and with the ACA expansion, we're all running into that difficulty of finding psychiatrists, and then finding psychiatrists who are culturally competent. And so how about this? A psychiatrist who is culturally competent in, let's choose El Salvadorian Spanish, who will see and is specializing in children, so we'll see a 12-year-old with an eating disorder and diabetes who has an insulin pump. Everybody's got a few of those, right? So those are two of the, I think, relatively universal challenges that we all face. And facing that looks different perhaps from your perspective than from ours, but it's the same challenge. The number of psychiatrists is low, is lacking, even in our urban areas where the number of mental health professionals is high, especially per capita. Those who are willing to see our folks are not numerous. So that's just mentioning a couple of the challenges that I think are universal. Now let me just ask, who has solved that?
I can comment on it anyway. I'm the point person in our small county to make an attempt at integrating our healthcare for folks. The systems are very siloed, and there's a lot of assumptions made between providers. And we've been able to build a team of not only behavioral health and primary care clinic providers in this one pilot that we're doing, but we've also brought on board our managed care organization and their subcontractor for the behavioral health benefit. And we're just now starting to have a conversation about why aren't you seeing that person that I assessed and referred to you? And we have the health plan there at the table too. And so we're starting to look at screening tools and how the referrals are being made, who's talking to who has a relationship with who. Very foundational work, but it's so important because there's so many assumptions being made by everybody that person's going to get the care that they need at that moment. If you give them a phone number. And that's not happening.
Well, I think that's everyone heard that, right? I think that's a truth that I'll just admit, I seem to have to learn that over and over again. That a great referral is worthless if the person doesn't follow through. And so it's no accident that we more and more are talking about integration. And integration, not so much co-location, because co-location, I have finally learned, is an interim step. I have spent time at a clinic in the general northern area that does a really good job of providing physical health care. That clinic has a psychiatrist that is there many days a week, nearly full time. And I'm going to use refer in two different ways in this sentence. They refer to sending a patient to see that psychiatrist who's in the same building. They refer to that as referring out. So even putting the right people in the right place is not sufficient, because we have to rethink how we're thinking about how the health care is delivered. So I mean that's really a good point. Thank you. Does anyone else have a comment on that particular issue? I mean, I think it's something that we all face, and I just hope that whenever someone comes up with the fix for it, the fix that is beyond what, the federal government is starting to do some things about the relative shortages in various medical specialties. So there is some incentivizing away from some of the specialties, cardiothoracic surgeons, how many do we need really? Versus how many pediatricians do we need? How many psychiatrists do we need? How many family practice docs do we need? So there is some work happening at a very high level to try to address this, but that's not going to change things in the next 5 years. That's a 15-year proposition. Yes?
Well, I mean, I think we haven't fixed it, but part of the way we've addressed the shortage of psychiatry services in Nevada County is we try to offer flexibility wherever we can. So flexible days that the person works, flexible hours, flexibility in terms of how we pay them by the hour versus driving time, building flexibility in terms of charting and documentation. And then the big one is, people have to be paid enough. So I think most of us that work in small counties, I mean, it's really, really always hard to attract psychiatrists. And so a lot of the small counties just try to pay more to attract people. And I think that's something that, you can't just treat them all the same. It's not, when the market is really, really small and there's a limited pool, you have to pay more to get people.
Anybody disagree with that? Go ahead.
No, I just wanted to add that, in San Diego County, besides being Kumbaya, we use telepsychiatry to address the issue of shortness of psychiatrists, and actually those psychiatrists that come is somewhere else in California. So it's not really right there in San Diego. And we hire for specialty in language as well. And also through our Workforce Education and Training Program under the Mental Health Services Act, we have been able over the past 3 to 4 years start to develop the nurse practitioner cadre in San Diego based on three universities that have nursing programs, and the yield will be kind of down the road.
Right.
But the residency or the internship piece was key because their interest, of course, our interest was that the nurse practitioners would specialize in psychiatry. So that's a couple of other things that we're working on.
Is anyone else using telepsychiatry? Okay, because I want to hear about that, because it offers quite a potential solution. There's a limitation that at least we've come across, which is presentation centers. There's something about the safety of exchanging information, which again is another one of those universal challenges that we face. that has at least some folks who are using telepsychiatry restricted by where the presentation centers are. In other words, where does the patient have to be in order to get that care? In my mind, telepsychiatry means, goodness, they have a computer with a camera in their home. They can see a psychiatrist. I think ultimately that's what it ought to be. It ain't that way. At least that's not been my experience. So in these rural counties where it's really easy to think, okay, well, telepsychiatry ought to solve that problem, it's not quite the great big solution that it would initially appear to be. So I was glad to see there were some hands up, and there was someone who had a question, but I'd like to hear some more about what people are doing with telepsychiatry. Yes?
Well, I promised Adrian that I would mention in one of these groups about national health for shortage areas. We're in Closer County, very small county, rural county, but we're an eligible center for people who can come to get forgiveness for student loans, up to $60,000 for a 2-year commitment. So that might not necessarily help us that much, but it does help with other licensed providers. It adds quite a bit of value to the salaries to get those forgiveness. I will say something about telepsychiatry. I haven't been in a couple counties where it's been used. It's got pluses and minuses. I agree with you. It should be a home-based service. I worked in places where we went out and got the client to make sure they didn't miss it, because we were going to get billed with it. We're going to get billed for the psychiatrist whether the person showed up or not, and we had to turn around and bill Medicaid for it and couldn't get the full reimbursement for it. So it's great in some circumstances. Children seem to be really good with it. They're fine with it. Not so much for paranoid adults. I don't want to talk to the television anymore than they are already.
Yeah, television's talk. Yeah, exactly. Television's already spending too much time talking to them.
So I think it's, a while back, Davis and some other people, there was some funding to help with that, to connect to their doctors and that source. I've talked to directors in Southern California. They're contracted with the psychiatrists in Florida.
Right.
Because the technology allows them to do so. But I agree with you. I think it should be a home service.
I mean, who hasn't Skyped by now? And if you're a Gmail person, you've probably done Hangouts, which are even cooler than Skype. There were a couple of people who raised hands about telepsychiatry. Were there some other comments on that?
We use telepsychiatry both on the children's and the adult side, but it's usually as an adjunct to our psychiatrists. What we've had recently is a number of our psychiatrists retire. It has been historically an older workforce that is in psychiatry. So we've used the telepsychiatry to assist in those situations, but we're actively recruiting for psychiatrists pretty much ongoing.
Yes.
In Fresno County, we have a little more heavily relied on telepsychiatry than we would like. In our adult system here, we only have one full-time psychiatrist, and we're quite a large county. We have quite a number of retired psychiatrists who stay on as extra help, and we're piecemealing that. We have quite a large telepsychiatry contract with a provider. We're actually amending that contract because we were concerned we might lose the provider because of our rate structure. So we're actually amending our contract to allow them, during times when there's perhaps a no-show, that they would still receive compensation from us, that we would utilize them for things like consultation with our teams. And so our contract hadn't allowed that kind of compensation, so we're amending it so as not to lose our provider. We do use telepsychiatry across age populations, so with our youth and with adults, with older adults, with transition age youth. But we're actively recruiting. We are just in the process of going to our Board of Supervisors to request a salary increase, which we don't think will be enough to recruit, but it'll be better than our current structures.
Which I'm sure sounds familiar to lots of people in the room. And what you're also doing is you're saying, you're acknowledging that it's not necessarily just salary. There are other ways that the compensation can be made more compelling. And so to be able to say to a provider, okay, these no-shows, which are nearly entirely, I won't say entirely, but nearly entirely out of your control, there will still be some compensation. That's a way of delivering the message that your time is valuable. There was a hand over here.
Yeah, so my question is whether or not anybody in Northern California or the state is using these almost like plug-and-play telehealth providers from other states, and if there's any barriers to using those based on licensing or credentialing or requirements along those lines.
Well, I heard someone talking about someone who's in Florida. How about others?
The contract we have in Fresno County is with a physician group, and they have physicians who are working from across the nation. They just happen to also be licensed in California. So they maintain the license across state lines.
Right. So as there's mumbling about this, the issue is that they have to be licensed in California, and California is not an easy place to be licensed in. Now, there are not an easy place in which to be licensed. I want to be correct. So there are discussions at a high level about that because of the advent of electronic medical records and electronic other ways of being electronically available to patients. There are discussions. Does that make sense anymore to have state licensing? Well, it does make sense, but perhaps there is something else that can be done that would ease that pathway toward telepsychiatry. Or maybe what happens is at the end of the day, every stakeholder in this decides, no, we really don't want people practicing across state lines because of X, Y, or Z. I don't know how that discussion is going to end, but that discussion is happening.
You also made a comment about the doctor's time being valued, and I think that that's another thing that kind of eroded. So for example, in Santa Cruz County, there had been a time to do the budget cuts, we had less case managers, so they kind of came up with this concept of meds only. And they're all counties significantly impaired by their mental illness patients. And the doctors now have these very large meds only caseloads, which one makes the doctors feel overwhelmed. But then when one of those patients goes south, it's a little problematic because they don't have a case manager. Right. So we take sometimes we're not getting people out as quickly as we should. So it's like how to like undo that carefully. We have a new behavioral health director who's like, I would really like to change this. And I think that we've lost the doctors as consultants to our teams in our counties. And another example is one of our medical clinics. Oh, so glad I got a hold of you. We have this patient. You need to get him in to see a psychiatrist right away. It was an antisocial man who had court mandated for anger management and was making threatening statements to female clinicians. I was like, gosh, you guys need help with him, but he doesn't need an appointment with a psychiatrist. That's not on his list of needs. So it's like if they'd had better consultation, they would have assigned him to a female provider, gotten him his classes much earlier. So I think it's hard. There's a lot of different levels. I guess about this reorganization, so it seems like a nice watershed moment with ACA, but
Yeah, I think there's a pretty widespread feeling that the advent of ACA presents lots of opportunities. Challenges, obviously, but there are some opportunities. You mentioned docs with caseloads that are meds only. There are some of us, I'll speak for psychiatrists, there are some of us who really thrive in that. And all we want to do is see patients and diagnose and prescribe meds. There are others of us who really probably belong in New York City, where in psychiatry in New York, we're much more likely to be doing therapy than we are on the West Coast. So there's a spectrum of desires and needs within psychiatry. The table at which we were sitting at lunch, we were talking about this transition that David Pallon mentioned about it used to be that you'd create relationships with these, especially the severely mentally ill patients that were coming in for a clubhouse type program. You'd create relationships with them that you knew were going to last for years and years and years because this is the place they came. This is where they got what they needed. They needed you, and so that need would go on forever. And 10, 12 years ago, we began to understand that really, if we're going to really serve these patients, we need to think about graduation. We need to think about transitioning them on. And one of the barriers to that is us, is our feeling that really we need to hold on to that. I thought you did that really well. That continues to be a challenge because the advent of managed care is here. And really we need to be about evidence-based treatment that moves people in a direction. There's still going to be some folks who really the best they can do is is Clubhouse Forever, but it's not that many. So allowing for the variability in what our clinicians would like to do, allowing for the variability in what they're able to do, almost can seem like a luxury because we're just so short of people who can provide the service. I wanted to, someone mentioned nurse practitioners, and I just wonder how many of our counties have nurse practitioners and specifically psychiatric nurse practitioners been part of the solution? And has that been, does anyone want to comment on that?
Sure. Yeah, I'm from Mendocino County, and we brought out a nurse practitioner about a year and a half ago, and part of the deal was they contracted with the county, he contracted the county for 24 hours a week and the FQ for 16 hours a week. And so seeing him as a bridge. And he's a psychiatric nurse practitioner with that specific requirement. And it's worked real well, but we need more of him.
Right. Right. Well, that sounds like almost luck that you found someone.
9 months of back and forth and just getting the county to understand value and try and figure out ways and then talk with FQs. It took 9 months. It just happened. He was leaving he had done some duty in the prison system. And he was very qualified and just ready to move on.
Correct.
But it took 9 months.
Was supervision of that nurse practitioner an issue? Was that easy to settle?
Well, it's fairly easy because he brought a lot of value. We did disagreement. I forget the name of it now.
Collaboration?
Yeah, a collaborative agreement. And it works out with effective value. He saved us a lot of pain.
Cool. Others with experience with, yes?
I've worked in a couple counties that have used nurse practitioners and psychiatric nurse practitioners. Worked out very well. One in Merced, we've had an individual that was actually in an outlying clinic. It made it much easier. A lot of our psychiatrists would not prefer residing in our outlying areas. And so it was easier to have a nurse practitioner actually do the work out there, which is 40 miles away. The psychiatrist didn't want to spend their time driving out there either, and we didn't want to pay them for that time going out there as well. And so it made it more practical and feasible to have a nurse practitioner out there and receive the supervision from a psychiatrist that we had on staff. So that was in our current county. In our other county, we actually paid for the education to have 2 of our nurses to go through the program in Fresno, and just to get them on board as nurse practitioners and to go the extra level. And it worked out really well. It was money well spent. They came to our county, they planned on staying with our county. We did have that as an agreement that they would stay, but at least for a time, that we could hold them. But that actually turned out to be a very positive investment on our part, and it opened up the door for opportunity for this new scope of practice, you might say, to be brought into our county. So, a couple of thoughts.
I'm Kim with CIBHS, and we have a grant we're doing with UCSF School of Nursing that's funded through the Robert Wood Johnson Foundation, and we're studying, looking at barriers and opportunities for psychiatric mental health nurse practitioners in California and county mental health systems. So we're studying 5 counties over a 2-year process, and we've got about 3, and it's really interesting looking at how they're making counties are making it work, how they work, what the challenges are, the supervision issues. We're also doing some financial modeling from it. So when it ends, here it ends, we hope that we have some data we can share with the rest of the state around this.
I'm salivating. I want to see the data.
It's really interesting, and how even, I would say probably the most important thing is a champion at the top.
Yes.
A leader who says, this is a good thing. And psychiatrists who agree. That's all I can say.
There are some initiatives, now going back to the fact that we're a health plan, there are some initiatives that we have partnered with providers in doing. And I will tell you that their success rests in large part on whether there is a champion, and especially a physician champion, interested in making it work. Absolutely, with nurse practitioners, and I can tell you from experience, when we brought in some nurse practitioners at D.D. Hirsch, there were some of my psychiatrists who were absolutely happy, and some of them who were nearly offended. So, that had my work cut out for me. I needed to educate them, but that's one of the things that we have to deal with when we talk about bringing in nurse practitioners. I just wonder, for people who are familiar with using nurse practitioners, especially those, as you said, who have made the transition more recently from RN to RNP, are there funding stream challenges with having them work? Do you find that you have to separate your billing, that's a nursing function versus that's an NP function? I'm seeing shaking heads no. Cool. Because I think there were at the beginning of our foray.
Depending on the setting they're in, because I know with our county operated program in Sacramento County, we have a nurse practitioner who feels a little frustrated. She did go to school to get the psychiatric piece to it, but her background is in primary care, and now she's working in a mental health clinic, and all our billing has to be billed towards the primary psychiatric disorder. So while she may be able to assist individuals and do the coordinated care with the primary care doctor, she's not able to bill for that specifically. She's billing for case coordination, but most of her services, her assessment and progress notes are billed towards the psychiatric diagnosis.
So then my question is, who says?
Medi-Cal?
Because
It's a scope issue.
it is a scope issue, but it becomes, go ahead.
Well, I was going to say, because that's one of the things that we looked at when we were going to put these individuals through the education and pay for it. It was actually a psychiatric nurse practitioner program.
Right.
That was already in place. That was the only way we could do it. On the other side, it becomes a medical issue as opposed to a psychiatric issue. They can do services, but it's limited. And so we actually went the extra step. They have the DSNs already, and then we ended up putting them through the psych program, and it worked out great.
So what I wonder is, at the level of a provider, does it make a difference in terms of your billing, whether they can bill Psych NP versus RN services? Or is it 6 of one, half a dozen of the other? Or does anyone know?
RN would be different, but we're talking, whether they have they're a family nurse practitioner or a Psych NP, whether it doesn't matter.
Okay. So NP is NP no matter what? Okay. All right. Any other comments on that stuff? Yes?
I have a comment on the shortage issue in general, nothing to do with nurse practitioners.
I don't want to hear it then. Please, go ahead.
Backwards, I know, but I'll be brief. I have no trouble believing we may not have enough psychiatrists per capita in California. That's probably true. But I'd be really curious to know if anybody had any data about how many of the psychiatrists we have are part of commercial networks. Because you know from your D.D. Hirsch experience that the reimbursement rate for med support through specialty mental health under the carve-out is much more generous, which allows me to pay my public sector psychiatrists not great salaries, but good enough that I can attract and keep good people. We also have a commercial side of our business, and I can't discharge people into the community because there aren't people in the community that are willing to be part of the narrow network panels because the reimbursement rates are abysmal. And I think someone has to address that, and I don't understand. I wasn't an economic majors, but usually when there's a supply and demand issue, if there's not enough, if there's a lot of demand, which there is, no one can debate that, and not enough supply, usually the price goes up of supply. That doesn't seem to be happening.
Well, I have some thoughts about that, but before I express them, I just wonder if there are other responses. Yes?
So I work for a firm called RBA, and we just finished a study with OSHPD about supply and demand of people in the public mental health workforce. So the number of psychiatrists, for example, or NPs, or frankly, any licensed or certified professional public mental health workforce, we grabbed licensing data and then compared it to people who were registered in NPI, so they're at least seeing Medicare or Medi-Cal. It didn't get compared to who's in the private networks as much, but it just gives you the flip side of that. But there are supply and demand projections in there, and I'm pretty sure it's on the OSHPD website now.
Thank you.
Yeah.
Other? Yes?
Yeah, we just finished increasing the psychiatric rate for adult and children psychiatrists from $154 an hour to $175. So we're losing to higher paying entities, whether it's the legal system or the health plan or the fee-for-service sector. So we had to make that decision, effectively October 1st. And for our contracted providers. Our system is mainly contracted by 80%.
Right.
So.
There was another, yes.
Well, I'm hoping we can also hear from you about what Anthem is doing or is planning on doing. We've been sharing some of our strategies. I mean, it's both for psychiatrists and therapists. There's just almost none in our county. You have to leave the county to find someone on your panel. So I'm just really interested in what your plans are.
I'm glad you asked that because I was going to formulate my comment in the form of a question. Because similar to the rates issue, the issue of the limited scope, or not scope, but the limited licensure that exists with commercial plans is a huge problem in terms of having to have LCSWs or psychiatrists. When most of us in the public system are utilizing interns registered to work with their licenses, and that's how we make it work.
Yeah. Well, that's that's part of what my comment was going to be, that the question of what the reimbursement is and what a clinician sees working in a CMHC type setting or an FQ type setting versus being out in the community and contracting with an Anthem or someone else. And the difference really is that when you say to a clinician, and let's use psychiatrists, you say to a psychiatrist, okay, come work here, and pretty much all you have to do is work. You don't have to, for the most part, have your insurance handled, you don't have to spend a lot of time with billing, you don't have to hire staff to run your front office. There's a lot of stuff that you won't have to do if you come and work at this clinic, and we'll pay you this salary. Versus offering what would be the same hourly rate to someone who has her own office, has a front office, has billing staff, has the overhead of malpractice and other insurances. Those are very different propositions. So when an Anthem talks to Dr. X and says, we'd like you to be part of our network, Dr. X may initially say, sure, that sounds right. And then Dr. X has been in practice a while and understands now what it really costs her to do this service. You run into the problem that we run into, which is we've got a roster of people who say they are Anthem providers for our Medi-Cal patients, but when we call them with a patient, they say, oh no, we're not accepting. This is a real problem for us, and you're seeing it because sometimes it's the patient that you've seen that you're kind of properly passing toward us, and we're trying to find the provider. I'm glad that you said, because what I was going to come around to is we run into the very same restriction, but it's fairly glaring for us because it's not, we're a clinic and we can't see. We've got this one patient, and this patient needs to see someone, and we can't find them. So we end up, someone mentioned geographics, you go further and further to try to find someone who will see them. We do, Joe spends, I couldn't tell you how many, I think even today, there have been emails about this very issue where we're trying to find someone to see our patients and can't, even though if you look, there's this roster. So we run into it, and we haven't figured out the right solution yet. Ultimately, I think the solution is going to be our partnerships with you. The solution, I think, is going to be finding a way to make it so that, especially, and I know LA County best, but in the northern counties as well, finding providers who initially see themselves as seeing the severely mentally ill, who are interested in expanding the kinds of people that they see, and then partnering with us to see those folks. I think that's what's ultimately going to happen, but I don't know. I'm new. I get to play the new card for a while. I think Karen someone was saying that this morning. It was Karen. I think I'm in my 4th month now, so I get to play that card for a while longer. But that's, ultimately, I think that's what's going to happen, because I don't see, in the short term anyway, I don't see there being this huge growth of individual clinicians who are willing to see our folks. And I think our partners are going to be both mental health centers and FQs, physical health providers, who are creating or expanding their ability to provide behavioral health care. And in fact, it's those latter that I think are going to be the best matches, because it's I think easier to ease into seeing behavioral health patients if you're starting with mild to moderate folks. There's another part to this, which has to do with stigma. And having spent 14 years at D.D. Hirsch, erasing stigma is a huge chunk of what I think is important. And psychiatry is the redheaded bastard stepchild of medicine. It has been. It's less so today, but it still is. So mental health care and mental illness are seen, mental health care is still seen as optional. I mean, there are a lot of people who just see it as optional. And you look at, you confront people with numbers. You talk about the cost of major depressive illness. And especially if you talk to people at FQs who are seeing the obese, hypertensive, diabetic folks, those are our folks. You treat their depression and lots of those problems begin to melt away, but it's still optional. So those of us who are primarily in mental health really still have our work cut out for us in trying to address that, because ultimately our ability to address that directly affects the health of our folks.
Tom had a question. I'm wondering also if after that I can introduce Joe, since she's
Sure,
done a lot
I've been
of work
talking
in
a
terms
lot.
of
Yeah.
working with the counties.
Sure.
So you talked about the panels that you have, and I was wondering how often they get updated so that you know what specialties you have out there, because we've had difficulty on our child psychiatrist side getting a pediatrician to check someone before we start the medication. So, and going through the panels, it's like you call and you call and you call, and it's like, no. So I'm wondering how frequently those get updated so that we have actually a panel that's viable for us.
They get updated. The answer is they get updated very frequently. They get updated very frequently. In fact, they get updated every time I get an email from one of our case managers who says, I'm trying to find a provider in this general area and haven't been able to, that whole roster gets run through and updated. So in Alameda County, in Santa Clara County, and less so in Sacramento County. We don't seem to have big challenges in Sacramento, but those two especially, Alameda and Santa Clara, and Contra Costa, those rosters get updated frequently because we have challenges in those counties.
How about in the 18-county expansion area, the very rural area?
Well,
there's a lot of distance.
There is a huge amount of distance. And there, actually, we have challenges, but they're the expected challenges. You got somebody in this town, and it's 40 miles from that town, and that's where the provider is. But there's also some sense of understanding that if you live in a county that's this huge and you live here, there's an understanding that you really are going to have to drive to get to the provider. So though we have challenges in the very rural counties, and we have this rural expansion, which has been a challenge in and of itself, again, there's something about the expectation that it won't be 4 blocks down the street that you can go to see your provider. You're going to have to go a little bit further. And there have been I'm going to stop. There have been some interesting solutions proposed, including mobile. There are even some folks, people familiar with CBAS, community-based adult services. You know, those providers are, especially in the rural counties, are few and far between. Somebody has finally figured out that, you know, you can kind of put that in a great big van if you plan it well. So there are people who are thinking creatively about solving some of those problems, even at the level of CBAS, which is pretty cool, and I'm glad to see it. Let me stop talking and let Joe come up.
And I'm interested in Joe being able to talk with all of you also, because I see the questions are moving toward more of the specificity around really how do you build these partnerships between mental health plans and managed care plans, given the fact that there's been a really wonderful description about many of these problems are shared, and yet they seem to really be worked on at this point, still pretty much in silos. I'm really happy to have Jo here. She's very involved in the Care Coordination Collaborative that CIBHS sponsors, which works in a very focused way on relationship building between mental health plans and managed care plans and substance use disorder agencies in order to be able to support care coordination. And Jo's a clinical social worker. She came from San Diego State University. She has a very varied background. Her primary focus is on the SMI population. She had worked at the San Diego Gifford Clinic and at the Vista Hill Foundation, Crisis Stabilization, and she'd been a program director with the Alpine Special Treatment Center. She is very interested in working with children and families with disabilities. And then while she had been working at the Alpine Special Treatment Center, Anthem Blue Cross snatched her up and recruited her, and she went over to the plan side. And so, Jo, with that, I'm going to just kind of open it up for you.
All right. Thank you very much. Appreciate that kind introduction. I want to go back real quick to address some what we're doing to update our networks, because for you all, you would be going to Anthem's website, looking on Provider Finder. That is probably not updated as frequently as us folks on the operational side would like it. It is updated. I know our networks team sends out every 6 months, or at least yearly, but I believe it's actually every 6 months, practice update questionnaires for providers to list what their specialties are. When I first started with Anthem, I worked on the commercial side, and so it's only been almost a year, so I'm not going to be able to use the newbie card anymore, that I'm now working on the Medicaid side of the house. But on the commercial side, operationally, what my experience has been is that, the providers get that sheet and they tick off everything. Oh yeah, I'm skilled in autism, eating disorders, bipolar, blah, blah, blah. They mark everything on the list. And so I oftentimes would question, are they really being honest about what they really are skilled in? So sometimes I question that when I look up a provider on that site. So I would prefer to call them to confirm what their experience level is and their specialties. Anthem very much wants to portray that information accurately, but that information from coming into us and getting loaded onto the website, there is a delay, unfortunately. One of the things that I find challenging, to go back to the challenges, is developing those relationships. Historically, California Medicaid with Anthem Blue Cross was primarily the physical health benefit. And so now with the behavioral health benefit being carved in, I was brought in. We ramped up our case management and utilization management team to be able to address the behavioral health issues. And historically with Anthem, because it was primarily a physical health benefit, we had network relations team that were regionally based, and they were the liaisons that would go out to the clinics, and then they were the ones that have those relationships established with the FQHCs, with the community mental health, well, not necessarily with them, but with the rural health clinics, and with they're the ones who have those established relationships. So for me and my team coming into it, that's been my struggle is trying to identify and develop and create those relationships. So a lot of times I'm having to default back to those network relation liaison staff because they're the ones who actually know the people in the clinic. They go to your sites, they meet you, they work with your staff, they help you resolve your claims issues. So I'm a little bit envious of that because I'm wanting that relationship because I'm the one who can help and who knows the behavioral health benefit more intimately than the network liaison does. And yes.
There you go.
All right. Just pass them on down. Maybe we'll bring out more, and I will do so. But you can call me. It's best to call me on my cell phone. It's 619-933-9703. You can call me anytime, day or night. I don't care. You can email me. I'm usually very good about responding very quickly unless I'm out of the office.
Can you do that number again?
Certainly. 619-933-9703. And that's, one thing, when I got hired in, I'm the manager for our utilization management and case management program. When I first came into this, I was thinking, okay, I'm managing, direct work with our members and our providers. I wasn't anticipating that I would be doing more high-level work, so all of a sudden now I'm having to review MOUs and, and just explain those and discuss those and come up with, developing that care coordination process. And I'm finding that quite, a little bit challenging. And I'm also envious of San Diego, and I live in San Diego, and I used to attend some of those meetings, so it's like, okay, I'm, in these MOUs, I push back to my network liaisons and going, I want, to have that contact list like San Diego developed. I want names of who I can reach out to, to be able to resolve cases that are falling through the cracks or cases where we need, better coordination to resolve that. Yes. No, but I'm finding that I am, in a sense, doing more of that because of the issues of not being able to have a provider. And like I said, our networks team worked very hard to develop a robust network and meet the access standards. And so we thought we had a great network. And then my case managers in trying to, refer our members to a psychiatrist, they call and it's like, okay, here we go. We found 5 psychiatrists that are in our network that say they take Medi-Cal, and then we call every single one of them, and they refused. And what happened was, I don't know if these, when we contract with them, we send them the fee schedule, so they should know it ahead of time. But I don't know if they just don't bother to read the packets or what. But, all of a sudden they say, oh, well, the reimbursement rates are too low. I can't see any more people. Or I'm only able to see 5 Medi-Cal clients in my practice. I'm willing to, set aside 5 slots for Medi-Cal. They're full, so I can't see anyone. I might be able to see somebody in 6 months. Well, that's an access issue. We need this person seen now.
Moderates on one side, that really the managed care plans were going to do what they could to include more people in the specialty system, because the reality is the funding stream's there, the system is set up for it. But from what I'm hearing from you guys and what I'm hearing, from the Kumbaya in San Diego, that doesn't sound like it's the case. And I don't quite understand why.
It has to do with capacity. The healthcare plans are not set up, and we're not set up to provide specialty mental health.
No, I understand that. I understand that. But so, if you've got, it just seems like, at least in the San Diego example, and I'm not hearing with you, it's not a default to the specialty system.
Right.
It's, where I assumed that would be, because that is where the capacity is, and that is where the expertise is.
Well, actually, that was a challenge because we were hoping, we have reached out to some of our DMH partners in the various counties, and a lot of them came back and said, no, we won't contract with you to have our psychiatrists see your mild to moderate. They've refused. Many of them refused because they felt it was too difficult to change their financial system, that, you know, to be able to bill for that, you know, I have to bill Anthem or I have to bill the state, you know. So they weren't willing to, they felt they were already at capacity staffing wise. They couldn't add additional population in, and it was too challenging for them to set up the financial aspects to manage that. Also, we run into issues where, okay, we've contracted with the psychiatrist, so we refer to there and then have them say, oh, well, that member does, you know, this is a psychiatrist who's at a community clinic or at a rural clinic, and they say, well, this member isn't a patient at our clinic. They have to be a patient of our clinic for us to see them. You know, and so then we're like, oh my gosh, you know, we didn't understand that. You know, we thought you contracted for Medicaid. Well, it's only for people who are already enrolled in your clinic. So, you know, and of course our members are like, well, I like my doctor over here. I don't want to change PCP so I can see a psychiatrist. So that's also very challenging for us.
For Anthem, do the fees schedules or the reimbursement, does it vary based on needs? So if it's in a rural community, it would vary through providers?
No, the state set that fee schedule. And from what I understand, it's not adjusted based on, you know, need or location or whatnot. What we are having to do because of the access issues, we are then doing the negotiating and doing single case agreements, and a lot of the times we're ending up having to pay the commercial fee schedule in order to get that member seen.
Let me just make sure of something, Joe. So the state sets fees, but when it comes to contracting, if we were to come to you and say, let's come to an agreement that would allow you to see this number of patients, that's something that we can negotiate together.
And actually, counties now select their own maximum allowable cost, whereas it was called SMA before. The state set that up. So now that's why I'm able to go 175, because there's not a limit. But that was just recent as a part of the Affordable Care Act. But we set our own rates.
So my question is the rate for Medi-Cal managed care and if they're in specialty mental health is vastly different. I mean, it's completely different. So when a provider is coming to you and looking at negotiating the agreement, it's where do you fall in that range from, you know, Medi-Cal managed care versus specialty mental health, and if the client qualifies for specialty mental health.
Okay, I'm not sure I would know that, because I don't know what they're paid on the specialty mental health side, and I don't
we're paid by the minute, so it can be anywhere from, you know, $2.03 a minute up to, you know, $4 a minute for psychiatric care.
And that actually represents one of the challenges that we have to figure out how to surmount, because that billing per minute just confuses our contracting people. They don't know how to think about that. So the conversation often stops because they're going like, what? And then you guys are going, well, of course. And it's actually something that maybe we can make some headway on today, because I'm serious. We have to find a way of getting these folks seen. So there is some flexibility when it comes to actually contracting, but when it comes to the rates, like the rates that we show, that's a different set of
So I still have
calculations.
three questions. Chris, do you still have a question? And then Michelle, and then Terry.
It's sort of the same thing. It's, I feel like we could solve this problem. You know, if we all got together and we sat down and figured this out, this is about money and rates and accessibility.
So what Duane and I were talking about,
Nice
just
to have a forum for really doing that.
Yeah, and Duane and I were talking about that a moment ago, and so we're going to come back to that definitely before the end of this session, and let's just make certain that we get some of those more discrete questions kind of answered, sort of the information back and forth, but what Chris is raising is a really critical point, and so obviously we're not going to be able to do that all in this session, but let's think about some options after the session. So Michelle and then Terry.
Yeah, my question is really feedback on Chris's. I heard Duane say that we're able to negotiate the rate up based on the population that we're able to serve, and I'm wondering what the size of that population would have to be
I'm curious about that. And I think that this question about negotiating rates between the health plans and the CBOs is a really large issue. And I'm wondering if this session doesn't cover that, if CIBHS has a vision for hosting those conversations around the state through technical assistance.
Yeah.
Sounds familiar.
Yeah. We are thinking along the same line. Yeah, we're going to talk about it more. We hadn't planned it before this session, but now as I'm hearing questions come up, what we're going to do is talk about that, and then I'll kind of bring it back to CIBHS. But because
We should reach out. We'd love to help make that happen, I think.
Okay, yeah, and it's you and I can do that too. Okay, great. So we commit to that. And sorry,
Back
I have
to-
questions too, though, sorry.
It's actually not a question, more of a comment and a suggestion. I just want to be candid because I sometimes have a reputation for that. I'm a behavioral health director in a small rural county that's in the dual system. And we've had experience with Anthem through CMSP and Path to Health, and we've not been paid in a timely manner historically. I don't blame anybody in this room. Cash flow is the critical issue in keeping services and capacity where it needs to be for the community. So that's a concern. I was not given the option. The other entity wants to contract with me as a provider. Anthem did not. This appears to be an MOU. There's no exchange of funds. So it's another issue. And a small suggestion, we need to build capacity together. So if we worked at placing people in community mental health that could both serve your beneficiaries and our beneficiaries, we'd both be better off.
Absolutely.
And it's developing those relationships. And that's what, I want to try and get this back to, because that's what's so important. We need those collaborative relationships and how to do that. I would really love to see either, some kind of either Medicaid statewide EHR that, we can log in and access to, and then those members that are assigned, to our plans or whatever, then we're able to pull their data. I think that would make it facilitate coordinating care much more easier. I think that's, it still remains a challenge. I know for us, a lot of times, it's some of those cases that, when a member is in a medical inpatient bed and they have a comorbid psychiatric issue, it's working on that discharge plan and getting them, how are we going to get them transitioned over? And some of these are some of our, what Anthem would feel might be an SMI, and it's getting our DMH partners to see that or agree to that. Some of our challenges in particular happen to be those members with eating disorders, because we have to go through the access line, and and they're focused on functional impairment. Well, an eating disorder person's going to look high functioning, far as they can do their ADLs, they have housing, they're able to dress, they're able to eat, they can get themselves to appointments and so on and so forth. So so at first pass, the screener on the access call will say, well, go to your managed care plan, you don't meet our medical necessity criteria. And it's like, so then I have to push back and say, no, they, their BMI is like 11, they only, they're 5'5" and they weigh 70 pounds. We need to get them, for example, we have another case where, in addition, this is an adolescent, in addition also has diabetes and an insulin pump. We need to get her into a residential treatment level of care. Her, she's, is severely impaired. And, fighting with them over, well, we don't have contracts with any facilities. How are we going to fund it? Will Anthem help pay for that residential level of care? And we're like, but that owns to you. And, and then my fear is, because of this particular person, is because of the diabetes in addition to the eating disorder, she's even at higher risk. But it's getting our partners to recognize our level of concern and that we feel this person really does need this level of care, and getting getting them to appreciate that and understand that yes, this doesn't meet your SMI criteria, but that level of care is carved out to you. How can we facilitate getting this member in? And because of those delays and them pushing back, and we're both pushing at each other, saying, no, it's you, no, it's us, no, it's you, that member ends up having to go back into an inpatient medical facility because it took too long to try to get that level of care secured.
I think the issue here, this is a perfect example of a situation that we have in supervised nursing facilities and the health plan not paying, and San Diego saying, well, yes, it's your obligation, exactly the same scenario. But here's the issue. The issue is, why do we have to focus on what is the primary diagnosis? You mean to say that the eating disorder is secondary to the other physical, or do you mean to say that the psychiatric is, why should it even be an issue of duality? You got to treat both. One is not more important of the other. Many times, an individual with psychosis is not able to provide his own insulin, And so I think we need to get a little bit past beyond the payer and the funding and look at it from a clinical perspective as to what is of most important to this person. And so I think those are some of the challenges that we still have to overcome in this new venture.
And if I could comment, all kidding aside, this is exactly the kind of thing that I think wouldn't happen in San Diego because of the relationship that you all enjoy among the plans there. And the patient to whom the case to which Joe is referring ultimately is being solved because we found that we actually do have a relationship in that county that allowed us to get to the person who could figure out, yes, this is our responsibility, yes, we can get this done and we can get it done quickly. Before we realized that that relationship existed, we were having this circular argument. And let me, just to be clear, because it's Anthem's name out there, let me just be clear that while all this was going on, we authorized care for this person on an outpatient basis. That was not our responsibility. Well, we authorized it because we wanted to do what we could to maintain this patient until we got to the ultimate treatment for her, or him. But it's exactly what you're talking. It's why, honestly, I envy San Diego, because this patient wouldn't have had this last admission if we had been able to get this solved very quickly.
Right. In addition, again, it's always those most challenging cases that, that stand out in the forefront. And I'm thinking of another situation where we had a member who was in a medical bed because she swallows objects and, paper clips, pins, needles, and has other severe, OCD and other behaviors and, cluster B access 2 issues. And, she would be in a medical bed. We'd try to get a psychiatrist in. We'd try to get her, moved over to a psych bed. But, getting that transition and working with the DMH partner to get that transition wouldn't happen. It got to a point where on the medical side, we would start denying the medical admit, saying, no, this is a psychiatric issue. But then again, because she swallowed another object, it's like, okay, back into a medical bed. And the difficulty was, okay, we would work with them, okay, this is her discharge date, we need to get her in. But the problem was they couldn't get her in for a week, so she goes home, swallows another object, she's back in the next day. It was like we couldn't get her seen soon enough to be able to get her hooked up with outpatient resources. And, she was just a constant yo-yo. I mean, for over a year, constant yo-yo. And of course, this was happening last year before the behavioral health carve-in. It was just a constant yo-yo. We could not get her hooked up with county mental health services in a timely enough fashion to get those relationships and care established for her, that she would just constantly go back into inpatient. And unfortunately, she has since died as a result of these behaviors. So it's those are some of my challenges that I don't want to have that type of situation. I want these relationships so that when we have a serious issue in a serious case like this, what can we do to provide more expedient care? Can we get someone from DMH to see her while she's still inpatient to start developing that relationship so that when she discharges, she can go right in and get the care so she isn't bouncing back into the ER and back into a hospital again? So those are, so I'm very, I want these relationships. And again, for me, it's my frustration level because, we're finding out that some of these relationships do exist, but again, it's with that network liaison and not with my team. And it's my team that needs that relationship because of the behavioral health carbon. And so, I'm very glad to be here and to see everybody here and start, I got to meet Rin face to face. We've been on some meetings together, but, now I have a face. And, I'm hoping again, that being here, that we can start establishing those relationships, start meeting and start getting names of, okay, who can I call? Who can I contact? And that's what I'm wanting. And so I want to be that contact for you also when you have a member that is maybe perhaps ready to graduate or maybe needs, referrals for an Anthem provider, that, you can call me and we will work to get that member care. And believe me, for those areas where we're having access issues, I have my team members, I am calling every single psychiatrist on a list, who's on our commercial network and saying, will you see our member? I'm going to send you over to networks to discuss a rate. And, if worse comes to worse, we're going to pay you your commercial rate. But, hopefully our first goal is to try to attempt something a little bit less than that. But, we're willing to do that to get our members seen. This is something that is very important to us. And I know it's very important to all of you. So I want to work with all of you to make this happen. And to, so that's my goal. And I know we all share those same frustrations. Some of the additional challenges. Yes.
Can you, either of you address this issue of licensure at all in terms of the limitations? Because I think the things that you're talking about, are some of what would be needed as rehabilitative types of service that don't need a license.
Yes. Anthem does allow registered interns, postgraduate interns to see a member. They just have to be supervised and the billing has to be done under that licensed supervisor.
Is that new?
Yes, it's fairly recently. I think the state just recently agreed that registered interns can provide members. Can provide treatment. So yes.
It's one of the.
Jen, was that released in an information notice?
It's in the ADA?
No.
It's one of the silver linings of the whole ADA cloud, which is that the state recognized that there's something that has to change about who can bill and how things can be billed. Because under ADA, that's a whole different world of providers. So it's part of that same thing.
Also, we also limitations by some managed care folks, but license not.
Because I know at the beginning of the year, at one point, MFTs weren't allowed. No, Anthem, MFTs are allowed, registered interns are allowed. Now, graduate student interns, no. But postgraduate registered interns, gaining hours for licensure, yes, they can see our members, very much so. They just have to be, the authorization request just has to have the supervising licensed provider, preferably contracted provider on there. But if not, let us know and we'll work to contract. But yeah, so yeah, thank you. You're very welcome. Other challenges, the fact that because a lot of the FQHCs, rural clinics, do have a behavioral component built in, but the challenge is that they can't see, the same provider on the same day. I really feel that's a big barrier because you want that warm handoff. You're going to have a higher success rate if you can say, okay, come on over here. I want to introduce you to Susie. She's going to be really, whatever. But, but because it's like, oh, here's the warm handoff, but she'll see you next week because we can't see you in the same day. If they could be seen in the same day, you can hook them in. You're better likely to have better compliance, better, them keeping their appointments because they were able to get seen and get that relationship started while they're there. I'm a firm believer in, striking while the iron's hot. They're there in your door. Let's see them. And unfortunately, because of the funding issues, that's not allowed. Also challenges, because we don't have shared access to information, and because psychiatric inpatients carved out to DMH, so for my team, we don't know when our member's gone into inpatient psychiatric care. So it's hard to coordinate that care for when they get out because we don't know when they went in, when they get out. We don't necessarily know if they are accessing services at DMH or not. So it's how can we get that information? And if there was some kind of shared electronic records, that would be so much easier. It would be easier for medication reconciliation, which is very important as well. Yes.
I don't know if you were actually asking this the question or just talking, but you could access that information because for many counties, all of the patients that get hospitalized go to an emergency room first, where they're receiving an evaluation, a mental health evaluation that isn't billed to us, it's billed to you.
Right, but that's considered.
So you do know when they get evaluated.
Our medical team knows. The behavioral health team doesn't. And that's the problem. And it's even within Anthem, it could be a different billings. It's a different system, so we don't know when someone's in a medical admit because that goes under, the ER visit goes under medical. So our BH team isn't aware of that because we don't get those electronic census. That goes to the medical team. So it's an integration issue even within Anthem, integrating behavioral health and physical health.
So do you authorize the admissions?
No.
No.
Yeah.
Yeah.
I mean, there are a bunch of problems in there.
Yeah. Exactly. So so there's that
And that's
not
why,
necessarily
I'll just
misdirection,
say
but-
this. That's why ultimately, this carve-in, carve-out business doesn't serve patients. It doesn't serve them. It serves us in some ways. It serves, we have vested interests. Let's just say it. We each have vested interests. But for our patients, it doesn't make sense to have different funding streams, different carve-ins, carve-outs. It does not help them. And so ultimately, that's going to have to change.
But doesn't it in a way impact them? Because I mean, if when we're listening to, the cultural competency discussion earlier this morning, and I know that this definitely impacts my agency as well, is so much about what our work is about building a relationship with our clients so that they trust us. That's really hard to do if you're authorized for 20 minutes. Or what's going to happen when it does become, or if it all does become managed care, Medi-Cal managed care. How, we will be struggling within our own agency and with our staff in terms of that shift being 180-degree shift in terms of really looking at building a relationship and taking that time to build the relationship, which we're currently being reimbursed for, and now that the possibility that we won't. So in terms of bringing in the clients that we want to serve, that's where I see that there can be a real disconnect in terms of, especially in terms of talking about providing culturally competent services. And will those clients lose out? Don't know the answer. We're hoping to find a solution.
I think I would think that ultimately there's a way to advocate for people within a larger system. I'm not popular in my neighborhood where I grew up by saying that the NAACP exists so that it won't have to exist. I was on the board of the LA Gay and Lesbian Center, which I think exists so that ultimately it won't have to exist. So advocacy, I think, can happen in a larger context. It doesn't have to be that there is a Korean American mental health center to make sure that Korean Americans get mental health. I think it's needed now. Ultimately, it's not. Now, I can be accused of being Pollyanna, and that's fine. I'm aware of that. But,
that's not your name.
No, it's not. You're right. That's not my name. But people have said that.
I'm
our next step would be to commit to ongoing meetings. Which means you need to come up from San Diego, come to the rural area and really see us and get to know us. And, you know, I'm committing that Nevada County will be at those meetings if you guys come to the meeting. I'm sure other rural counties will do the same.
Oh, I would love to.
Because I mean, one of the things that we have in our little rural county, yes, we are rockin' beautiful, but we do not have, we don't have providers, so we call you guys. And we're not even talking psychiatrists, I'm just talking like, you know, therapists, you know. And so I feel like when I send somebody to you, on all honesty, I'm kind of throwing them away. I'm kind of saying to them, see you later, good luck, you know, and that doesn't feel good. That's not, none of us want that, and I know neither do you. So let's meet, we should become friends. Yeah. So who's going to set these meetings up?
So Michelle and I are going to talk afterwards. Michelle representing the Providers Association. I work with California Institute for Behavioral Health Services. We'll bring in Molly from CBHDA and kind of think through how is it that we organize this. Because what I don't want to do, I know that there are already meetings that are being organized between mental health plans and managed care plans. And so I don't want it to be sort of a chaotic, let's just all meet next week.
Right.
But let Michelle and Molly and I take some time to talk and think through the best way to do this. But I do understand the urgency of time. You know, and so to not wait for forever to.
It is urgent because in the meantime, I mean, I could tell you kids that are really struggling.
Yeah.
And adults, you know, and we don't want deaths.
Yeah.
And we don't want kids that are moderate to all of a sudden become like super severe.
Right.
So.
And let me say that in the meantime, I mean, one of the things that Anthem did when they hired me is they hired somebody who really likes relationships. So in the meantime, I'm getting around to the counties, not just on the phone. I'm getting around and meeting people, and I enjoy that. So I haven't been up to your county yet, but I'll
Come on
get
up.
There was, CBHC has done managed care behavioral health meetings, and they also do this right now for small counties for a couple meetings. So there has been some meetings done along this line. So it's not like it hasn't existed or we're starting to do it. It's probably something that we probably need to focus more on a more routine basis. And, you know, I think there's a real difference when you start talking about how in Northern California with the expansion area, you have one provider or one managed care program in some of the counties, and then you have two managed care programs in the other counties. So, and the dynamics are different because of that. So, but there are some ongoing meetings happening.
Yes, and you know, I have attended several meetings with different counties and as well as FQHCs. We did some presentations, and I think that's a great start. We need to go further, and so I'm very much receptive to that.
I know our focus in here is behavioral health, but our psychiatrists sometimes need consultation with other medical specialists. So we cross over with dual responsibilities. Even if we're treating someone with a significant mental illness, they might need a referral to a neurologist. So recently our child psychiatrist obtained a referral for a child for a neurology consult, but it was in Costa Mesa. And it was absolutely impossible for the family to get from Nevada County to Costa Mesa for a consult. And so there's a need for other medical specialty providers as well as just psychiatrists and therapists in order to treat the whole person. I just want to put that out there since we're running out of time.
And I do know that is, you know, those specialties are available through telehealth, but again, my experience has been because of these shortages, my case managers are talking with the members and offering telehealth, and all of them are refusing it, mainly because I think a lot of them are elderly, they're not computer savvy, or they don't understand what it is, and so it's like, you know, or they're trying to explain it like Skype, and it's like, So there's that reticence on our population to access telehealth. So I don't know if Anthem somehow, if we need to do more, some kind of member education, maybe some kind of commercial ads even, or some way of video way of showing them what telehealth is, maybe perhaps to better educate them. That might make them more receptive to accessing that care.
Just along the lines, and we are going to have to wrap up, but along the lines of relationships, which it turns out we've been talking about a lot. So in that particular situation, I'm not sure, but if I had gotten a call, what I would have done is spoken to one of my medical director colleagues on the physical health side and said, here's the situation. Now maybe they'd have said, no, it's closest, but you have nothing to lose by getting it, shouting it up the tree, because maybe there was another way to solve it. And again, it really does come down to these relationships. And I was kidding about San Diego, but I'm really serious. There is a huge amount to be said for having relationships, so that you're not cold calling someone, you're leaning over and saying, I have this thing, can you help? So I don't know if it would have made a difference in that situation, but it couldn't hurt to have tried. So it's something I would have wanted to know about, just to see if we could have fixed it.
Yeah.
We have limitations when it comes to providers, just as you do. So we can't always do what we thought we could do. We can't always find someone within 30 miles to see someone. We can't always find someone who speaks Korean. We're going to do the best that we can. I'm certainly going to do the best that I can. Jo does the best that she can. I think our company does the best that it can. I need to know about these historic not being paid on time, because if it's happened to you, it's happened to others. And so if I'm standing in front of someone and what they're thinking is, that company doesn't pay on time, it's helpful for me to know that. So I need to know that kind of stuff, and I need to know if it's still happening. And it's not like my hand is going to fix it, but if I know about it, I can certainly make noise. And I can make the case that, if that's what's happening, first of all, we need to fix it, and second of all, it's having an impact on our ability to do the rest of what we need to do. So all of those kinds are the kinds of things that we need to know, and I'll know them better if I'm sitting in the room with you occasionally.
And my clinicians work very closely with our providers, and when there is a claim issue, most of those providers contact my clinicians, and they have relationships established with our claims team, and they just have to email them and say, hey, XYZ provider has gotten a lot of, claim rejects, or her claims aren't processing. Here's the DCN numbers, follow up on it. And they get back right away, and they try to, work closely to resolve it. We do take these concerns very seriously. Yeah.
I think you might want to consider regionalizing in the North State. We're all small, most of us are friendly, but we are in the North State for a reason. So there might be some wisdom in looking at regional approaches and making provider networks available to regions as opposed to
I think we need to wrap up. I sure do want to thank people for participating, and I feel like people have been frank, which is great. I certainly have been as honest as I can be. But I appreciate the questions, I appreciate the discussion, and I definitely appreciate the information, the feedback, because we'll take that back. And I have to say again, I'm really serious. I show up, so you might see me up in your county.
I'm looking for it.
All right.
And so Michelle and I have committed, so we're going to meet and try to bring Molly, because we know that, the providers in the counties not always the same exact issues. And so there is a sign-in that's going around. Obviously, this isn't going to be the full group, but we really need to have your name and email. So there's one sign-in on this side and one sign-in on that side. So please